to do this after all this time?
I started it. Well,
Thank
give it a
you,
second.
dear. I'm like, there's so many screens and I can't ever find the one that I really, really want. All righty, so I'm presuming you're looking at the screen that has all aboard the E-train on it, right?
Yes.
Okay, cool. All right, so we are now on track 2. So last week, I'm just gonna say last week was the boring week. It's all that administrative stuff. Who cares, right? We barely even see that stuff when we're doing OASIS reviews. So now we're gonna get into the actual clinical side. And what I do want to point out, because I know I didn't talk about last week, was that the OASIS-E is effective with a Moon 90 date of January 1 of 2023 or later. So what that means is, let's just say for kicks and giggles, someone started an OASIS, let's say like December 28th. And they were waiting on, other clinicians. Maybe they had to go back again to actually see wounds or whatever it is. So their Moon 90 date comes actually January 1 or later. Guess what? They have to scrap that OASIS D1 they started and change it all over to an OASIS-E. So I don't know, I might have talked about this, sounds a little familiar in my head. Honestly, I don't remember what I did yesterday, much less last week. So this Moon 90 date, and we'll talk about, we'll have a whole things going on really in that last week of December, a lot of reminders coming out to watch for these things with the Moon 90s. So that'll come around again. So I'm not going to expect you to remember this right now. Like I said, I'll flood your inboxes that last week of, hey, as of today, let's start looking at those Moon 90s and see when they're actually dropping in. So that the correct OASIS is going to be dropped then. All right, so today we will go over sections B, C, and D. So first up, we have hearing. Hearing is coming back. It used to be in what, OASIS B or something like that. It was dropped along the lines. Well, now it is back. So B's, can everyone put themselves on mute, please? So B0200 is the hearing. And it talks about the ability to hear either with or without hearing appliances if they're normally used. So we have the choices running from adequate to minimal, moderate difficulty, and of course, highly impaired. So we just want to make sure when we're reviewing charts, see if the clinician has allowed the patient to use their normal hearing appliance if they have one. If someone's unable to respond to a standard hearing assessment due to cognitive impairments, then that's going to require, alternate assessment methods, such as, does the patient turn their head when they hear a noise at a normal level? So there's a difference between cognitive impairment of knowing what you're hearing versus did you hear a sound at all? So they just might need to, find a way to split that hair to figure out what's really going on. Is it a cognition versus just a straight hearing problem? I remember when my second nephew was born, turns out he just had, selective mallistening at that very, very early age of 3 months. And my mom would stand over and clap her hands to see if she can get a startle response because she thought he wasn't hearing. Turns out he just wasn't listening. So yeah, that was exciting.
I was wondering if they would put a man hearing or a husband, could be man, could be husband, hearing option on there. I hear you, right? But I'm ignoring you.
Exactly. There's a male selective hearing gene. Yes. It's the same one about not being able to find anything about in the refrigerator. Okay, so with the code 0 is adequate, obviously, you hear normal conversational speech, telephone group conversations, and you can even get the clinician should be able to glean some of this when they call to make their appointment. They actually got the patient on the phone or they get the wife on the phone. And if it's the wife, well, she just happened to answer and she's answering all the questions, or can he just not hear anything on the phone? So, get some information early on before you even step in the house. Code 1 is your minimal difficulty, where they have difficulty in some environments. Someone talks too softly or the setting's too noisy, where you have to throw all the grandkids out of the room to have a good conversation with your patient. Your code 2 is that moderate difficulty. So did the clinician document that they had to, we used to call it, I'd have to go out there with my therapy voice on and really be sure to enunciate and not get into my rapid New York speech that, I grew up with. Code 3 is your highly impaired. This is where you have that absence of useful hearing. they hear only some things, they fail to respond when the speaker maybe even address their tonal quality, or they're putting their therapy or clinician voice on. And even so, you're just kind of getting, that deer in the headlights look back at you. That would be maybe you're highly impaired. A dash, of course, is a valid response, because sometimes you just can't decide, are they not hearing me, or are they just not able to understand the hearing language, or, are they aphasic or something going on in some response that they're either not hearing, they're not processing what they're hearing, they just don't know how to respond. So with any of these hearing issues, is there any documentation that supports any codes you're going to use other than 0? You might just see that in the EMR itself, patient has hearing aids, or whatever the situation is. So just, look out for things like that. B1000 vision has gotten just a little bit different. That we trained people for years about how to look at this as, what is the patient's functional vision, right? Well, you know what? That one's out the door. Now we're back at, think of this as an eye chart. And the other big change as we go into OASIS-E is that magnifying glasses are now allowed under OASIS-E. So until December 31st, no magnifying glasses are to be considered here. Starting January 1, magnifying glasses are okay. So
welcome to the audio conferencing center. Please enter a conference.
With this B1000, it's the ability to see in adequate light, either with the glasses or other visual appliances. So they might have those big screen readers that you see some blind folks have, or technically legally blind folks might have to really blow everything up. So all that's okay in OASIS-E, because they're just looking for the ability to see objects nearby in their environment. So what's their environment? They might be adapting it in order to do their tasks that they want. So they should be able to demonstrate the ability to read a variety of print sizes. If the patient is unable to read out loud because of aphasia or illiteracy, this should be tested by another means, such as things such as looking at picture books, something with numbers instead of words, or pictures. They'll have a picture of their family, say, hey, who are these people? Can they even say, or if they're bringing the picture right up to their face, that's going to give you a good idea what their vision is like. So again, it has the code zeros running from adequate down to impaired, moderately, highly impaired, severely impaired, and of course, dash is always a valid response. And if the clinician has chosen anything from 1 through 4, hopefully we'll see documentation that supports that code choice. So you can see it just goes from, fine detail up to large print, not able to see newspaper headlines, or that highly impaired, are they tracking you at all, right? And of course, that's severely impaired where they're most likely blind, not just legally blind, but blind. Because we know legally blind has quite the range, right? Quite the spectrum of actual vision they might still have. So this really has become an eye chart as opposed to the functional vision. Okay, here it comes. Slido. And I think someone said they could actually run this from the deck. I don't know. I know when I play with it, I'm just in the presentation, but I've never come at it from the other side. But slido.com on any device. The code is 1615415. And people are starting to join in. We love Slido. Get a whole bunch of names on here before we move on to the actual question. And be sure you're also getting your sheets ready. I sent out last week the OASIS items because someone said, hey, I really need something to refer to because it's too hard to look back and find that item. So I sent out the sheet of just the OASIS-E's because everyone knows all the other stuff. But this is really the only stuff I'll ever be asking about on these Slidos is the E's. Give it just another few seconds. Starting to collect a bunch of names now. Okay, let's slow down a little. So the clinical assessment indicates the patient enjoys reading e-books on her tablet. Clinician notices the text size is set at 300%. The patient is able to read this readily with reading glasses. When shown text at 100%, the patient is unable to read. So what is the proper score for this patient? And I also took the timer off. So you just click on, and you refer back to B1000. See if we're starting to get anybody in here. There we go. We need some people to review that item. So that B1000, I'm gonna open up my book so I don't go scrambling your heads here, flipping the screens back and forth. So B1000, 0 is your adequate. Well, it says sees fine detail such as regular print. Impaired is sees large print. So she's doing okay at that 300%, which would be large print. 100% is your regular text size. So she's not seeing that. So it would not be that score of 0. Moderately impaired is limited vision, not able to see newspaper headlines. Well, at 300%, she's reading her ebook. So I would say, yeah, that, you know, I think we're comfortable with that score of 1 being impaired, seeing the large print, but not the regular print. Okay. There's our leaderboard. Everyone's like, oh, game on. Okay. And again, we know a lot of stuff is coming in because of the social determinants of health, and here's one of them. So we have health literacy. And the question the clinicians are going to be asking is, how often do you need to have someone help you when you read instructions, pamphlets, or other written material from your doctor or pharmacy? And they have never, rarely, sometimes, often, always. And then we have patient declines to respond and patient unable to respond. Now, this is a self-report item, which means no other source, even if it's the proxy, you know, their POA, whatever it might be, or the medical record saving, you know, giving you this answer, technically, we cannot use that information. It's just what the patient is telling you or has told the clinician on this item. So this is just about their the degree to which the patient has the ability to find, understand, and use the information and services to inform themselves for health-related decision and actions. So what you want to check as you're going through this is if you're getting some responses, especially up in the often and always you're seeing in the chart, you know, did they get the MSW in there? Right, just check to see, hey, you know, that might be a good idea. If someone's struggling with, you know, understanding their health information, you know, they might need some help in there. So perhaps an MSW is necessary to intervene and get that set up for them. CO100. So this is where there's two things that really have gotten a lot of attention with moving to OASIS-E, and one is the BIMS, the brief interview for mental status, and the other is the delirium, and then the subsequent upgrade from PHQ-2 to the PHQ-9. So the BIMS encompasses items really from C0100 through Z0500. And the question is, should it be conducted? And it says to attempt to conduct the interview with all patients. As you can see, there is no way out of this. The first one is 0, and that says that the patient is rarely or never understood, and it does give you a skip point onto the delirium item. Okay, so everyone's going to have to go to the delirium item, or it's yes, we should conduct this, and then it's going to force the clinician to go on and conduct this interview. There's no response that says, hey, you know what, this patient appears to be cognitively intact. We don't have to do this. Yeah, no, not an option. So this is going to be exciting to hear how agencies are handling this. So, like I said, you have the responses of no, which becomes a skip point, and that's where, the clinician should only be choosing that because maybe the patient can't respond verbally, they can't respond in writing or using any other method, or an interpreter is needed but not available. Or yes, and that's just go ahead, do the BIMS interview, and then dash is always a valid response, which means no information is available, which, that'd be tough to justify why someone's coming up with a dash, but I'm sure someone will somewhere. So what it is, it's the series of asking these questions. First, we have the repetition of the 3 words, and this is small because it really is not horribly important for us to learn the technique of it. It's just one of those things that we're going to be looking at it from the other side of, does it look like the clinician did it right in the chart? So we've got the repetition of the 3 words, the temporal orientation, which is, oriented to time and place, and the recall. And then that final one, the CY2023, is just the total of the scores. So in looking at these from Z0200 through the 500, for the first one, they want to record the maximum number of words that the patient correctly repeated on the first attempt. So that's where, back on the question, it was asking, I'm going to tell you 3 words and I want you to repeat them back to me. Right. So it's the sock, blue, and bed are the words that have been chosen for this. So the number of words, correct words from that list of sock, blue, and bed that come back on that first attempt, that's what gets recorded. Now, if you've seen the documentation that the clinician had to come back and give a cue again, and then again, and they're saying, okay, after 4 attempts, they finally got all 3 right. It doesn't matter. What did they get right on the first attempt? That's the only thing that's going to be scored. So that's the thing that we want to make sure is that if you have that documentation supporting that number of times they had to do queuing, make sure that only the number answered correctly on the first attempt is what has been coded there. 0 is a response. It can be for a nonsensical response. Tell me those 3 words. And I was doing this with my mom's neighbor. Mom's in an independent living facility. Her next door neighbor is, like minutes away from being put in a different facility because of Alzheimer's. But so I decided, kicks and giggles, I was going to do this with her. And I asked her, I said, okay, what were those 3 words? And she said, don't I know you from somewhere? So yeah, that would be nonsensical, right? It's like, that's not what we're talking about. And then she went on to talk about how, well, she lives in West Virginia now. It's like, okay, we're in Cincinnati, but okay. Yeah, so nonsensical, that'd be 0. It's not informative with respect to the item being rated. 0 could also be, that's none of your business. I'm just not going to answer you on this. Refusal to answer an item. Or 0 is, hey, you got it wrong. I told you red dress and chair. No, that's incorrect. Or 0 is, there was no answer, or could not recall. So I don't remember. I don't know. So any of those could be 0s. This can be exciting to see how the EMRs handle this, and that 0s have different meanings, which is going to mess things up on this next slide. So I put the difference between a 0 and a 0. All right, remember 0, nonsensical, lack of responses, refusal to answer, or because they got it wrong. So if they answered to the best of their abilities, but still answered all the CY0200 and CY0300 items incorrectly, and they coded it as a 0 because they got it wrong, you actually don't stop the interview. So if they got everything wrong, the clinician is to continue. But if all those 0s were because they were nonsensical, then you would stop the interview, and you're sitting there going, what? Yeah, so this is what that means. If we look on the right, we'll do the easy one first. So the Z0200 through the Z0300, which is the repetition of 3 words and the temporal orientation. Do you know what day it is? Do you know what year it is? Do you know what month it is? They got them all wrong. but they're answering you, but they got them all wrong just because, no, that's not correct. It's not 1982. It's actually, 2022. That's wrong. So if they got them all wrong, you keep going through the very last one, which is a recall item. On the left hand of the slide, we say, but if those zeros, because the answers have been nonsensical, or they're not responding to you, they're refusing to respond to you from Z0200 through Z0300, then you stop. You mark the 400 as a dash. Total scores is 99, which means it's a throwaway question, right? So, like I said, it's going to be interesting to see the way that EMR handles this, because a zero is a zero, but it's not really a zero. It could be because of, so yeah, things might get interesting. So we just have no idea how the EMR is going to handle this as far as the whole scoring is concerned, because the scoring in this C0500 is to add up all those things that they got, whatever the codes were for each item. They got, 2 of the 3 choices on recall, so they have a 2, so that scoring is a total of all his items, unless this whole thing just became a throwaway and then it's code 99, we're really unable to complete it because of these conditions. Either the patient's not playing along nicely in the sandbox, they're refusing to participate, or 4 or more items were 0 because they chose not to answer or gave you a nonsensical response, or if any of those items was coded with a dash, right? Which means we have incomplete information. To be incomplete, a patient had to choose not to answer or give completely unrelated, nonsensical responses to 4 or more items. Yes, that's just, we get those patients in home care where you're constantly looking at the caregiver for, so tell me what's really going on, because the patient's just not going to give you sensible responses. So, like I said, see, this item is going to become interesting when the EMR comes out. It's one of the first things I'm going to look at and say, how are they doing the scoring? Is the EMR going to total this stuff up? And how? All right, so that's the BIMS, brief interview for mental status. And then we have, so remember that score 0 of the BIM said, hey, no, they're not appropriate for this. So it's a skip point to this item now, the C1310, the signs and symptoms of delirium. So we're going to get here if we skipped the BIMS, or if we did the BIMS, we're still going to land here. So either way, everyone is still going to land at this item, which is really exciting. So I'm sorry, when I get my knee done, which I'm certain will be somewhere in the next 10 years, I'll get a knee replacement. When you come out and you start asking me these questions, I am going to throw something at you. So just tell that clinician on the phone, be prepared to duck, because now it's getting insulting. But so, again, there's just no way out of these questions. There's no skip point for this patient is cognitively intact. But there you go. So after you've done the BIMS, now we have the acute onset of mental status change. And the question is there evidence of an acute change in mental status from the patient's baseline? All right, let's think about this. The patient just came from the hospital, wherever, or the community. It's the first time you've ever seen this patient. You don't know their baseline. So this is going to be relying a lot on their caregiver if they're there, if there's anything in the documentation that indicates what their typical baseline is, right? Because you don't know. How do you compare something to something when you don't have the previous something as your knowledge? But okay, here it is. So we have, just getting there, the 0, the 1, yes, there is evidence, or no, there is not evidence. So simple question there. And then we have 3 other things to look at: inattention, disorganized thinking, and altered level of consciousness. And these do have some, good questions to them where the clinician probably will be able to answer them with the help of a caregiver if that's what's appropriate. Otherwise, if you don't have these issues, there's just going to be a whole bunch of zeros and the clinician's going to, blow right through this, which is okay. But the choices for the coding are 0, behavior not present; 1, behavior continuously present, does not fluctuate; or 2, the behavior is present, but it fluctuates. So it comes and goes, they change as the day goes. This might be your sundowners. So, again, it's just a matter of the clinicians getting used to what this information is here. Do we have any documentation that supports the code choices that they're making? So these might be, a little tough to parse out initially as clinicians get used to the documentation side of all this. I'm sure with, as they start getting into it, filling it out, and, it gets to the reviewer side and we start sending back questions of, hey, based on this, we're looking at it might be this. Hopefully there'll be a learning curve and they'll start getting more documentation support in to show why they're scoring what they're scoring. I don't know. It's all just guesswork at this point. So this just talks about, the different ways that the clinician can look at record documentation and talking to the family. So it's just stuff that we might want to look for as well in the documentation. With that, they came up with, this top square in the top left, the CAM assessment for the scoring methodology. So, doing this whole thing doesn't indicate whether or not they have delirium. And they said, well, if your choice of A equals 1 or your item B, C, or D equals 2 and this and that. Does anyone remember Venn diagrams from high school geometry and algebra classes? Yeah, that's what that's like. I don't do well with the words, so I came up with the picture one, starting with the little blue boxes, saying, okay, if this or that, then as long as you're also within the conditions of B equals 1 or 2 in the pink box, and then if those conditions are met, do they meet the conditions of what's in the big light blue box? So yeah, that's what has to be met for them to, say if someone has evidence of delirium. And even then there's no question that says, so after all this, is this patient delirious? It's just, people always say, I'm filling out this chart, so what do I do with that information? And the information basically is, if all of these items are in play and you say, yeah, they hit all of those criteria, then that's something that, if it's not noted in the medical record that this patient suffers from delirium, you might want to have a talk with their provider saying, hey, we did the CAM and based on the assessment, this is what they're looking at. Otherwise, do I see a lot happening with this? No, I don't. All right, we know M1700. This is just where it's hiding now. It's in this section, right? Section C, the cognitive items, right? This is at the time of assessment in the preceding 24 hours. That's a day of assessment item. We know M1710. This is the 14-day look back item, right? Just reported or observed within the last 14 days. So we know about this item. This is not new to us. Non-responsive at M17, 10, and 20, just a reminder, that means the patient is unable to respond or responds in a way that the clinician cannot make a good judgment about their level of orientation. Right, and that's when you're hoping that there's a caregiver around that you could talk to them about this. M1720 is also here. And again, it also has a 14-day look back period. DO-150, the patient move interview. So if you recognized right on the top there, A, little interest or pleasure in doing things, and B, feeling down, depressed, or hopeless, that's M1730, which is gone from the OASIS. It got ransacked. So it took those two items, the DO-150, and just made it its own item, right? So it's not part of that M1730 where you might have had to look at other types of formats for doing a depression interview. So now they just have the DO-150, the PHQ 2 to 9. And there are criteria to be met of moving on from just doing these two items to the full PHQ 9. And what they said was, if both A2 and B2, so that's row A, column 2, the symptom frequency, so column 1 is symptom presence, column 2 is symptom frequency. If they're both blank, you skip the rest of the interview. If they're both 0 or 1, you also skip, because then you're really not hitting any good criteria. So it's kind of your free pass to get out of this. So this is what they're also saying. So 9, where there's no response, right? Patient's not listening to you, you stop, right? The 9, the clinician should have entered in symptom presence and nothing in column 2. Hopefully the EMRs won't allow them to enter anything in there. But if you see like a dash or something, that's incorrect. That dash shouldn't be. And with that, the interview is stopped. They skip everything else and they're done. Also, if the symptom frequency is 0 or 1, again, you stopped. You're pretty much, you're in the clear. We're not seeing any depression issues here. You're free to go. You go to DO 160 for the total severity score, which is just the sum of column 2. And it's either going to be, 0, 1, or 2 is going to be the most, because you can only have scores of 0 or 1, and that's it. But if you're going higher, right, if your scores from that PHQ-2 are 2s or 3s in the symptom frequency of either of those rows, then you've got to go on and complete the entire PHQ-9, which is the rest of these questions. So now it's C through I, and you would have to go, well, the clinician would have to go through all of them. Again, listing the symptom presence, and if they have the presence, how often are they feeling that feeling. All right, time for Slido. You ready? Here it comes. The clinician must ask the patient to answer every item A through I in DO 150. That's your PHQ 2 to 9. Is that true or is that false? About half the people in so far. True or false that they have to answer every item? Slowing down. Okay. So good. It is false. They don't have to answer every item. Again, if they're the first two, A and B, were showing no signs of any problem, so they're either 0s or 1s for their symptom frequency, you do not have to move on to the rest of the PHQ-9 to finish out C through I. So it's just A and B that would be done, and you're done. So trick question. Always watch those ones that say must ask every item. No. There you go. Score's doing good. They're hanging tough there. All right, so this is the one that is just going to be, it's going to be humorous. That I'm hoping the EMR can figure out, because you look at these things, it says multiply this, multiply that. Yeah, no clinician is going to do that. They're going to look at that and go, nah. So don't have to worry about this. This is more of a humorous slide for me than anything else, because this is the actual guidance of how to score this item. Like, that's not going to happen. If you're missing items, or if it's this or it's this, then you do this. No. So again, we're praying the EMR has got this figured out. And then the last one we have is another social determinant of health item, the DO 700, social isolation. And it's asking, how often do you feel lonely or isolated from those around you? This is another self-report item, which means no other source can be used to identify the response. Dash is not a valid response. We need to get one. And of course, did the clinician order MSW if necessary? So if we look at some of these, we have never, okay, don't feel lonely or isolated. Really? Yeah, no, I'm pretty social. Sometimes, and then we have often and always. And of course, we always have 7, patient declines to respond, or 8, patient is unable to respond. So again, even with, the 7 or 8, if that's where you're looking, you can't go to the caregiver and say, look, they're not answering me, or they're unable to respond. What do you think the answer is? You can't do that. This is a patient self-report item, even if that means the patient is unable to report. So last Slido. Here we go. When asked about the social isolation, the patient's daughter states her dad often complains about feeling lonely. the patient refused to confirm or deny her statement because he knows it's worthless arguing with their daughter, right? What is the correct code for DO700? Halfway there. Answers are still coming in. Looks like we've slowed down. All right, so the correct response is 7. Patient, refused to respond because we can't take what the daughter is saying. So whoever chose A and B, nice try, but we can't take what the daughter is saying because this is a patient self-report item only. And he's refusing to give up the information. All right, so, well, we've got others. I mean, Laura has one because she's apparently fast on the keyboard there, but a lot of people have gotten them all right. So, hey, kudos to you. All right, so I'm going to shut down the screen. Stay on. Do we have any questions?
I'm not able to find to follow along. Like I can, and it's too little for me to see on your screen. Are these supposed to be in the smart sheets right now, or are they not there yet?
They're not there. The slide deck itself I'll put it in Smart Sheet later, but the one with the recording will be going into the Easy LMS.
Mm-hmm. I would just find it really helpful to be able to follow along and take notes as you're doing this. So if you could post it prior, it would be very, very helpful. And I'm having trouble with the Slido because I can't memorize everything on but it's okay.
Well, I sent out last week the attachment of the items themselves, so you can refer to them, see what they are. Maybe I can work that in the next one. I'll try and get like the responses in there. Yeah, I'm still tweaking this as we go along. I'm just learning to slide on myself, but maybe I can do that and get the responses in there and get a little more information. So I can't get screenshots in. I haven't figured that one out yet. I don't even know if it's possible, but I can certainly tweak that and just we'll keep trying to perfect this as we go.
No, it's I think it's good information. Just it would be nice to be able to follow along a little bit better. I'm doing the best I can though. Thank you though.
Okay, sure.
I appreciate it.
Yeah, no, like I said though, the PowerPoint itself will be up on Smartsheet later. I hesitate putting it up because then I don't want people not joining the meeting because they think, well, they can just read it. And I riff a lot, and that's sometimes where the good information comes. But I don't know, maybe I'll just take your words at it that you're going to listen in anyway. Or you can go back later and pull it up from Easy LMS and listen to the whole thing then. See what else I had to say besides what's showing in the slide. And also trying to think. Maybe the Slido should still work in the PowerPoint. Yeah. Got to have some fun with it, right? All right. So any other questions about this stuff? Any comments of what you think you're going to be looking at come review time with some of these items?
I think I'm gonna have to go over these assessment items a lot.
Yeah, I think I am so happy I'm not in the field anymore, because to have to do these, that the DO150 and the delirium and the BIMs, no, thank you. That's just, yeah. Clinicians are going to have to do a lot of role play, a lot of learning to, if agencies start asking you, hey, how do we learn this stuff? Role play, role play, role play. And they have to be prepared for those that, verbally you can't communicate with, things are done in writing. Do they have flip cards? You know, do they have it printed out? You know, it's in the guidance manual here. Print these pages out. Oasis Answers has made a lovely set of flip cards that we had to play with when I was at the CUSC conference a couple weeks ago, where, you know, the clinician sees it, you know, this flip card set, the clinician sees the question to ask, and the patient is seeing the responses they can choose from. Then you just keep flipping along, and you would know from the clinician side what's coming, and the patient is just seeing. It was really kind of awesome the way they did these flip cards, but you know, agencies are going to have to come up with something because not everyone is verbal. So yeah, it's going to be interesting how agencies handle these really tough questions. You know, the BIMS and the CAM and all that is not easy for a clinician. The level of detail that they're looking at here and the whole process to it. You know, this isn't your simple, you know, walk across the room and let me assess how I think you did with that. This is let me dive into your emotions and your feelings and your brain power.
I have a question about the CAM one. So if
Yeah.
you're reading the record and the patient had, you know, delirium and stuff in the hospital, gets home, doesn't have it, do we account for that at all in that sense? You know, they don't have it anymore. I mean, is this a look back thing? Is this a now thing? What is this?
Hang on, let me check the look back period on that.
Okay.
It doesn't say at all, which generally means it's a 24-hour look back, you know, day of assessment type of thing, you know, what's happening today and what happened in the past 24 hours before I got here. Yeah, so, you know, my impression is that, you know, you're looking at this patient now and you're trying to decide, are they different now than how they were in the past 24 hours? Like I said, I don't see anything. And this is probably one of those things that we know that the OASIS help desk is getting flooded with questions regarding OASIS-E items, because that's the kind of thing that we need a little more clarification on that. You know, is it just the day of assessment and look back item, or do you want us to look back a little further, or, you know, compare to what? Like you said, they have it in their documentation that they suffer from delirium, but hey, it looks like they're having a good day today. So where do we go with this? So this is just one of those, I think the next round of Q&As and the January ones are going to be very exciting. We're going to start getting a whole lot of information, and just because of questions like this come in and they get submitted, and I think they're collecting them all right now instead of responding to any of us.
Thanks, Arlen.
And I'm going to send that in just to make sure it gets in. Anybody else? Something on the chat. There's a bubble up. Yeah, I feel sorry for the clinicians too. Yeah. All right. Okay, yeah, so if anyone has any questions to pop up later, you know, feel free to shoot it to me. Like I said, if I can't find an answer for it, I'll shoot it to OASIS, the help desk, and see if we can't get that on the books as well. Because trust me, whatever questions we're coming up with, so is everyone else across the United States. So these are, like I said, the Q&As are going to get real exciting for the October ones that roll out. And then, of course, January, when everyone starts putting it into implementation. And it's like, now that you're forced to use it, you're like, wait a minute, I have this situation. What do I do with it? So that's when we get a whole lot more guidance, is when something starts getting used. All righty. All right. Thanks everyone for attending, and we'll see you next week. Same time, same bat channel.
Thank you.
Thanks, Arlen.
Stop the recording.